Good morning. This is Babak, Larian. I'm sorry I'm late. Today I start the session with a heavy heart. As some of you may know, I'm Iranian. I was born and lived until my teenage years in Iran, and it's really hard to watch what's happening over there. I still have lots of friends and family in Iran, and breaks my heart to see what's going on there. The brutality, the mass murder, it's staggering. The numbers are staggering. The people of Iran don't greet each other. They say condolences to each other. So it's madness, basically. Madness at a level that is unprecedented. The official numbers are 3,000 to 5,000 dead. The reality is dramatically higher than that. Minimum of 50,000, if not more. Probably more. Everybody has had a loss. Everybody knows a family that has had a loss. Everybody has had some family member that's been hurt, injured, maimed, poked in the eye, some crazy thing. And the madness is not ending. So it really is. It's hard to watch, hard to live through these times, and it is what it is. In any case, I just had to get that off my chest, but let's go and talk about parathyroids now. So this is a hyperparathyroidism live question and answer, and there's a series of questions that have come in. I'll try to answer those questions, and then if there's time left, any more questions that come up during the course of the day, I will respond to those as well, or I'll do my very best. So the first question comes from Rika Mering. Hi, Dr. Larian. I had one parathyroid with an adenoma removed in July of 2025. PTH calcium went down with intraoperative testing, but 1 month later, PTH was 88. Upper limit of normal is 65. The calcium stays on the low end and vitamin D between 12 and 14, which is low. I get sick from vitamin D and biotin and even sunlight. I'm still experiencing symptoms like pressure in the head, tinnitus, which is ringing in the ear, spiking in blood pressure, heart palpitations, kidney pain, bladder infection, bone pain, although I use 1,000 milligrams of calcium per day in my diet. Can this be a calcium leak? My 24-hour urine calcium shows low calcium on no calcium diet and on a drip. Can it be hyperplasia? Kidney function is between 70 and above 189 from time to time. So, Rika, it depends on what your 24-hour urine test is showing. If it's after surgery, if you're after surgery, 24-hour urine calcium on a no calcium diet, but on a drip, I guess IV drip of calcium, I'm assuming, is low, that means that let me show you. That means that the calcium that is in your bloodstream is recognized by your kidney as being too low for what your body wants. So it's not filtering as much. It's also affected by the PTH, because the PTH that is being produced here by the parathyroids also goes to your kidneys and tells your kidneys get some more calcium back in the blood. So both this and the low calcium level are minimizing the amount of calcium in your 24-hour urine calcium, which means you're not getting enough calcium, right? So this is the opposite of calcium leak, right? So you don't have renal calcium leak. You probably are still going through the struggles of one of two things. Either your bones, which in a setting of hyperparathyroidism have lost a lot of calcium. So this is what it looks like regularly. And this is what happens when you have hyperparathyroidism. And you get a lot of calcium leaving, which causes these little gaps to form, which is what causes osteoporosis. All right? And so now your bones want to get all that calcium back. And so the level of calcium in your bloodstream is in a constant flux and struggling. So because your calcium in your blood is low and your kidney recognizes that it's low, and your parathyroid that no longer has the adenoma recognizes that it's low, it produces more PTH, right, to get some calcium into the bloodstream through the kidney, through the intestines. Now, if you add to that a problem with your intestines and malabsorption, then it complicates the situation. Seeing that your vitamin D is so low, I would switch to sublingual vitamin D so that you don't have intestinal absorption issues, right? Maybe start at lower doses, with half a drop a day, and slowly increase the sublingual vitamin D. As you say, it's making you sick. I would check my inactive, the 25 hydroxy vitamin D, also the 125 dihydroxy vitamin D, because this one is not normally checked in blood tests. So if this number is low, right, and this number is either low or normal, if this number is low, then what you may need is supplementation. This is a prescription, but with activated vitamin D, with rocalcitrol, This is another name for calcitriol, right? That's a prescription medication that can help that, and this is the active form that does improve the absorption of calcium in the intestines from 20% to 80%. So you are probably going through some version of hungry bone syndrome, but because your PTH is high, you're getting some of the side effects of high PTH, which is palpitations, blood pressure issues. If you still have kidney stones and you're passing the kidney stones, 6 months out is still not enough time for all the kidney stones to pass. They could be feeling the ramifications of that. But this is essentially a version of your hungry bone syndrome. And you need to stay ahead of it and get a little bit more information so you can react appropriately. The challenge that you have is the intolerance of vitamin D, but again, you may want to see if your calcitriol is low, and if it's low, take the rocalcitrol, which is a prescription, and take it from there. Hopefully this is helpful, Rika. Pam Farniak. Dr. Larian, your guidance has been invaluable to me in my prolonged journey of convincing physicians to provide appropriate care. I'm glad I could help. I'm now post-removal of all 4 glands, one being on the thymus, with autotransplantation of tissue in the sternocleidomastoid muscle. Great. After 12 years of hypercalcemia, my levels were within normal for 4 months post-op. Since then, my serum calcium has been low, 8.7, 7.8, and I am asymptomatic but do have osteoporosis, osteopenia noted 2 years ago. My vitamin D is 30. I'm seeking your advice on supplementation. Thank you for your expert advice, Pam. Pam, what would be important to know is your PTH level, right? And also if you're having any symptoms of low calcium. So if 8.1, 7.8 are low calcium numbers, you would on a regular basis get numbness and tingling in your fingertips or around your lips. So if you don't have that, and if your PTH levels are in the normal range, let's say anywhere between 20 to 30, and they hover around, but they go up and down, they show variability, which means the autotransplant parathyroid has worked, then around 8.1 is where your body wants you to be, all right? And your parathyroid is appropriately responding to it. That's a possibility. On the other hand, if your PTH numbers are too low, which means that once they took out all 4 of these parathyroids and transplanted one of them in the muscle, so if, let's say this is the muscle, and they transplanted one parathyroid, a half a parathyroid in the muscle, but it didn't take, and it's not alive, and so you have 0 PTH or exceedingly low PTH, not enough to service your body, then you're going to have to take activated vitamin D, because without PTH, the kidney doesn't transform supplemental vitamin D into the active form. So you would have to take recalcitrol and consume a lot of calcium, right? So that you can absorb it. And then monitor by looking at your labs. Look at recalcitrol, look at calcium and PTH, and see how your numbers are working. If you can't fine-tune it, a 24-hour urine calcium can also guide you, because the kidney has the same sensor for calcium. The calcium sensing receptor is both in the kidney and in the parathyroid glands, right? And so they're set for the same number, right? So if your 24-hour urine calcium is very low and your blood calcium is 8.1 and your PTH is non-existent, you just need to supplement more. And again, you can use those parameters to adjust, okay? So if you're on the line and you're seeing this, please share with us your PTH level and if you've done a 24-hour urine calcium, and I'll try to address it. Otherwise, get that information and adjust. And calcitriol is very, very essential to people who have low parathyroid function. And the reason for it is, again, I'm going to repeat, is without calcitriol, you only absorb 20% of the calcium in your intestines. With calcitriol, you absorb 80% of the calcium that you consume. It's a dramatic difference, right? So you really need this. Clarissa Hutcherson Whitaker. Will there be a video of this afterwards? Yes, I'm going to try to save it both on YouTube and Facebook, so you have access to it. But I was scheduled for a scan of my parathyroid today, and it was canceled because the insurance wouldn't pay for it. I'm sorry. I have stage 5 kidney disease, a genetic condition. My PTH is 416. I've been on calcitriol for several years. My calcium levels are normal. Should I try to appeal to insurance? Clarissa, it all depends on what scan you're talking about, right? It would be hard for me to imagine that your insurance would not approve getting an ultrasound, right? Simple enough. And then, generally speaking, thereafter, you're trying to figure out if you should do a sestamibi or a 4D CT scan. With kidney failures, 4D CT scans are not really an option because it affects your kidney even more, right? I mean, at stage 5 kidney disease, you probably don't have much kidney function anyways, but this can damage any remaining function, right? And so sestamibi, and the sestamibi, in the setting of hyperparathyroidism, I mean, in the setting of kidney failure, what you get is secondary hyperparathyroidism. Secondary hyperparathyroidism means, let me see if I have something to show you here. So primary, in a regular parathyroid environment, right, the parathyroids, all 4 of them are reacting to the level of calcium in the bloodstream. If the calcium is low, they produce more PTH. In the setting of secondary hyperparathyroidism due to kidney failure, right, you don't have reabsorption of calcium from the kidney. You don't have the enzyme available 1,4-hydroxylase, so you don't make this. And if you don't make this, you don't have absorption of calcium from your food, and therefore your parathyroid glands produce more and more PTH, which means they get bigger and bigger and bigger. And so essentially, all four of your parathyroid or all of your parathyroids are enlarged. The point of the scan is to see if your parathyroid, if any of your parathyroid, instead of being in your neck, are somewhere else, right? So if you look at the anatomy, typically speaking, the four parathyroid glands are, let me draw it in blue here. These are the four parathyroid glands, but 20% of the time they're not in these usual locations behind the thyroid there, and they can be anywhere. They can be all the way down in the chest, inside the thyroid, behind the breathing tube and voice box, in the covering of these vessels that are around these, can be in a sheath covering these vessels. So they can be hiding in all sorts of places, okay? And so the purpose of the scan is to find an ectopic parathyroid. If the scan you're looking for is I mean, I would start with an ultrasound, and that really doesn't require insurance approval. In terms of the sestamibi, I think you should fight. You should definitely fight and see. Because if you can find a parathyroid in an unusual location, then your surgeon can be more minimalistic and go to that location and remove that rather than just trying to explore to find it. So it is helpful and it's well worth the fight. And I think what you need to do is you need to have your doctor who's ordering the scan fight for you, because they're going to have the language of speaking to the reviewers in the insurance company and tell them, hey, we need to do this thing, rather than just kind of pushing you aside and not ignoring you, which is what insurance companies are very good at. And then, you know, if you've already had an ultrasound, if you send the ultrasound to them, along with your PTH number being so high, your calcium being so, you know, affected, and you're constantly having to correct it, having to take calcitriol, and this problem contributing to further problems that you have, and you're saying you feel awful and have lots of symptoms at a PTH of 416, you're going to have lots of symptoms, right? But definitely fight. Now, generally speaking, we recommend parathyroidectomy when people are in kidney failure and on dialysis when their PTH is over 800. But if you have lots of symptoms, and if your symptoms are these that's on this list, then list your symptoms and you know, with your doctor, and you know, have them write the letters for you and get this done, because that's what you need. You need your doctor to be advocating for you on this, besides just writing the prescription, getting on the phone and talking to the insurance company, basically. All right, and maybe have you be on the phone with them, all right, so that you can explain how much you're suffering. The other way to approach this is to go to the HR department. This is all American healthcare system related problems. But if you go to the human resources department of your company, right, they're the people who talk to the insurance plans that the company pays for. And if they call the insurance company and say, we have one of our employees who's having problems and he's not getting the service that they need, we need you to be taking care of this person and doing the scans that they require. Because they pay for your health insurance, the insurance company is not going to ignore them. And that's the madness we live in America. Good luck, dear. Kathy Namani, good afternoon. To you, hope you can understand this time as I can see a bit better now. Can you please explain a hypercellular adenoma? I had one in 2017. I was unwell from 2008 to 2017. Had an operation, 2 negative system EV scans prior to the operation. Leading up to that, my levels of PTH and calcium was low. PTH was 8.7. So calcium was either high normal, right? 2.2 to 2.6. So your calcium was 2.59, so at the upper limit of normal. And PTH is 8.7. If I remember correctly, the range of normal for PTH is somewhere around 6.5 is the upper limit of normal. So you have a high normal calcium, and so you have high normal calcium, which in a normal parathyroid, I mean, PTH should be low, but your PTH is above normal. So you have normal calcemic hyperparathyroidism, okay? So, but you had surgery and you had a hypercellular parathyroid adenoma. Okay? Let me just read the rest before. Oh, you have a dissertation. Holy mother. Okay, let's read the whole thing and see what I can figure out. So you've been educating yourself since 2008. You took vitamin D, and you had a 1.21 gram, a huge hypercellular adenoma removed in December 2017. Day after operation, my levels dropped to 2.12 and PTH to 2.14. Great. Then by July of 2018, calcium was 2.4 in the normal range, and your PTH was a little high. Vitamin D was normal. And Gersh said, I have hungry bones, so put me on 30,000 units. That's right, every 3 months of vitamin D, I guess. Okay. I was so ill that 2 years, especially after I got injections, being sick, literally such bone pain. I was telling the hospital that they keep saying it's good for you, but here in the UK they don't test 125, so you know that score. I came off around COVID, felt better, but my levels are showing no relationships. And here's the level: December 2018, 2.5, PTH 5.6. May 2019, calcium is 2.54, PTH is 2.46. Okay. All right. I'm sorry, I'm reading the rest. I have severe osteoporosis since 2015, and it has declined now to negative 3.3. I sneeze and I break ribs. All right. I need to, I'm sorry, you've written a lot, but I really need to see what your labs are today. Let me see. I've lived with illness since 2008. No life, no friends. Don't feel like doing anything hard. I have no will to. Can't even get dressed some days due to feeling rotten. And GB says besides herself trying to help, but her hands are tied. She keeps referring and just rejections. Okay. If you're listening to me, Kathy, if you're listening to me, if you can give me, January 28th, okay, got it, the latest lapse. So January 28th, 2025, calcium is 2.53, upper limit of normal, PTH is 2.46, good, and vitamin D is 90, Okay, so calcium is 2.46, PTH is 1.9, so calcium in the normal range, PTH on the low side of normal, vitamin D is 97.6, so all those numbers are okay. March of 2022, calcium is 2.26, PTH 4.2, vitamin D was high at 111. November of 2025, calcium is 2.44, PTH of 4.1. So, I mean, it looks like your parathyroid system is looking okay. I don't think the parathyroids are malfunctioning, Kathy. I'm sorry. I don't know what else could be causing it. You know, the cellularity on the pathology report is that the normal parathyroids and abnormal parathyroids under the microscope look the same. This is the ironies of ironies. Okay, so under the microscope, a normal parathyroid will look like this, where half are parathyroid cells. This is a big clump of parathyroid cells. Every single dot in there is a cell, the nucleus of a cell, right? And then these rounded things around it are fat. So normal parathyroid has equal amount of fat and parathyroid tissue. An abnormal parathyroid will have less fat and more parathyroid cells, right? All of these. So it's the proportionality of parathyroid cells. So when they say hypercellular parathyroid, that means there's a lot of cells, not a lot of fat. Hypercellular. That doesn't tell you that you have an adenoma. Okay? The only way to know if someone has an adenoma is if they have a hypercellular, sorry, let me go to, so if they have a hypercellular parathyroid with very little fat in it, right? And these are blood vessels, these. Okay? And then a rim of normal cellular parathyroid. This is a rim of normal, right? Which you can see here, normal parathyroid. And then this is the parathyroid adenoma, right? And the rim of normal cellular parathyroid, this rim here, is 50% fat, 50% cells. This confirms that what came out of you was an adenoma. What you're telling me is hypercellular parathyroid. So if the cut in the parathyroid was in this orientation, it would miss this thing entirely, and this would show a hypercellular parathyroid. If the cut, on the other hand, is in this orientation, then you would see hypercellular parathyroid here and normal cellular parathyroid there. That would tell you have an adenoma. So just because you have hypercellular, I can't tell if you had an adenoma or hyperplasia. But having said that, that was 2017, and 2025 numbers, your calcium and PTH numbers are normal. So it looks to me that you no longer have hyperparathyroidism, right? Now, your bone loss is an issue, and that may mean that you're not absorbing enough calcium or vitamin D. I think a 24-hour urine calcium will guide you on that, even though your numbers look pretty normal, to see if you need to go a different direction, or if you are postmenopausal or menopausal, you may consider taking hormone replacement therapy, because that can help improve your bone density. So, but based on what I see today, it doesn't look like you have active hyperparathyroidism. I'm sorry, Kathy. I wish I could do more. Good luck, my dear. Nicole Baradat. Why do the parathyroid glands become diseased in the first place? Is this being studied? I know most people are women, and that area of science seems slow. So the response from Jill Hitchcock is, Nicole, it's slow because it mainly affects women. And there's a distinct gender bias in medicine. All that is true. I think it doesn't get enough attention because of that, but also because it is not a deadly disease. It is not something that kills people immediately. It is poorly understood in the sense that it is much more common than believed, right? We think it happens in 0.125% of the population. In the Canadian osteoporosis study, they found that it was present in 5% of the adult population over the age of 30, right? So the information is so different. Great majority of people who have it are not treated, right? Is that because they're women, or is that because we just don't understand it? Probably a mixture of both. It's supposed to be diagnosed with endocrinologists, but endocrinologists don't treat it. Surgeons treat it. When surgeons treat it, the patients don't go back to endocrinologists. So those people who diagnose it don't really have a good grasp of how much of an impact this treatment has on the patient, even though they may read it in their textbooks and in research. Seeing a patient and seeing how life has dramatically changed is different than reading it in a textbook. And so it's kind of an orphan disease where there's no one person treating it. You know, there's some surgeons like me who like to diagnose and treat, but majority of surgeons are thyroid surgeons who get their referrals for thyroid disease, thyroid cancer from endocrinologists. So they do what the endocrinologists say, and so that relationship is what guides the treatment. And so there's so many layers to this. And then, although there have been many famous people like Jamie Foxx and Gary Shandling who had hyperparathyroidism and others, there hasn't been a person who has really stood up and wanted to say. And I think if some, you know what it is? I think when you have this disease, it runs you down so much. It takes you away from your life so much that once you get it treated and you feel well, you want to get back to that life, right? And because even though it felt awful, it wasn't deadly. It wasn't like it was imminently killing you. And it wasn't like when HIV hit and a massive proportion of our society was just being demolished and wiped out, right? That it was so impactful, so scary that we had to all take notice. It's not like breast cancer, like it's everybody has a family member who's had and been affected, and it's in the news and it's in the forefront. Lung cancer, smoking, like it doesn't have that aura to it, you know. It kills you over a 30-40 year period, right? It kills your soul much sooner than that, but it's so it is an orphan disease. That's why it's not. So why does it happen? It happens always because there's a mutation. So normal parathyroid cells, normal parathyroid glands. So the way normal parathyroid glands function is that on the surface of every parathyroid, there's a calcium sensing receptor, this orangish looking thing, that thing, right? When enough calcium is attached to the sensors, it tells the gland, don't release parathyroid hormone outside of this gland into the bloodstream. And when there's not enough calcium, it does that. So the relationship between calcium and PTH is this inverse curve, right? So, and on this inverse curve, there is this point we call the calcium set point, right? So, the calcium set point is the ideal number this particular person wants their calcium to be, which is 9.5, right? So when their calcium goes from 9.5, let me and here it is. So calcium set point of 9.5, right? Calcium versus PTH. So if the calcium goes any different number from this, the parathyroid reacts. Now, this green box is the range of normal, right? So even in the range of normal, someone who has a normal parathyroid function will find themselves at calciums can be high, but the PTH is extremely low, or calciums can be very low, right? And the PTH will be very high. That relationship of numbers tells you that this person is normal. They're just going along their curve, right? So when the calcium goes from 9.5 to 9.4, PTH rises quickly. And then when the calcium goes from 9.5 to 9.6, PTH drops quickly. That's a normal parathyroid function. All right, controlled by the calcium sensing receptor on the surface of every parathyroid cells that is genetically set for a certain number. In this case, 9.5. It could be that my number is 8.7, right? So that's my number, which means my graph will look like this. And someone else can have a calcium set point of 10, which means their graph will look like this. That's the basics. Now, how do we get hyperparathyroidism? This is how it happens. If there's a mutation in the gene for that sensor in one cell, right, exposed to some sort of environmental toxin. So that cell is now set for a calcium of 11 versus the normal cells, which are set for a calcium of 9. And as the calcium number goes up, the normal cells go down their curve and work less and less, while the abnormal cell is working harder and harder to get you to that 11 number. And when it works harder, it duplicates and gets bigger and bigger and bigger until it turns into a tumor, right? So what does that mean? That means the normal cells follow calcium of 9.0, but the abnormal cells are now trying to get you to 11. So the number, your calcium, as the calcium goes up, the normal parathyroids work less and less and less and less. They don't stop working, but they work less. And the abnormal cell is coming up to get itself to this 11 number, okay? And so it's a genetic mutation that gives you that. It is always a genetic mutation that sets this up, right? And we don't know exactly what environmental toxins are causing this. We know radiation exposure does it, right? So if you had lymphoma as a child and you get radiated in your neck, 20 years later you can develop this, right? And so that's the only one we know. Is that the only reason? No. Majority of the patients that I treat for hyperparathyroidism never have had radiation of any meaningful type, right? And you don't see the hyperparathyroidism happening more often in X-ray technicians or in people who have a lot of CT scans. The dose of radiation is not high enough for that, but it is high for someone who had therapeutic radiation, right? All right, let me move on to Nicole's more questions. I'm in Parathyroid PHPT Facebook forum. Last year, a chap in his 40s posted that he had just had surgery in NHS. His hyperparathyroid had only been identified 3 months prior. I could almost hear the collective intake of breath from all the women in the group who fight for years while their bodies were slowly being destroyed. Yeah, you know, it's a massive disservice to women, right? That doctors don't understand this disease and they give themselves the right to box women into this category of being hysterical. It's I don't even know how to it's awful, right? But some of the symptoms of hyperparathyroidism is very much like the symptoms of just generally getting old, right? I'm 55 and I have 3 kids. So I have fatigue, I have joint pain, my I have memory problems. I can't remember names so well. My kids would tell you that I'm irritable. My sleep is terrible as compared to what it was 10 years ago, right? And I have to actually put concentrated effort into creating an environment where I can sleep well. I I have more acid issues. I'm not constipated, but I have a bunch of these symptoms, right? And frequent urination. Well, I I got a prostate, so frequent urination and nighttime urination is common, right? It's not here yet, but it's coming. So I have a lot of the symptoms that are common in people who have hyperparathyroidism, right? And so do a lot of people, right? And this disease happens most often in women in their middle ages, which will have these symptoms as they naturally age. But the difference is that they know that this happened to them all of a sudden. That it wasn't that a gradual, memory issue. Like, oh my God, I was working and I was very active and motivated, and I wanted to do things. I wanted to hike and exercise and go to parties and socialize and go to the museums, do all sorts of things I enjoyed. And in the past 3 years, I just don't feel like doing any of it. I'm not interested. My relationship is suffering. Sex is not what it used to be. I just don't have a libido or interest. And, my partner is not happy with that. And it sucks. Life sucks. I feel like all of a sudden I got old, right? Well, if you're a 50-year-old woman, the first thing your doctor is going to do is not say, you have hyperparathyroidism. He's going to say, you're perimenopausal. You have hormonal issues. You're anxious. You're depressed. Let me put you on an antidepressant. Let me try to give you hormone therapy. And maybe you have fibromyalgia. Maybe you have chronic fatigue syndrome. Let me see. Let's throw all these labels at you, right? Way before they look at your calcium and say, your calcium has been slightly elevated and been tracking upwards for the past 10 years. That's interesting, right? That's why. That's why women get boxed into this thing. And it's terrible. It is awful. But it is what it is, right? And I wish I could have access to doctors to educate them about this. Wherever I can, I do. Anyways, let me move on and see. One of the responses in here from Jill is, I got lucky and had a really good doctor from the time of diagnosis. Surgery was about a month. Where things failed with me was that I had been having symptoms for at least 5 years, including my blood work being off, and nothing was said until I developed kidney stones and was referred to a urologist. And it really is, if your blood test shows a high calcium, alarmingly high calcium, that alarms your doctor, or if you have had a doctor that has seen this before. Urologists that treat kidney stones tend to see hyperparathyroidism. So I'm like, we should test for it. And that's where it is. And then it goes on to say, Nicole goes on to say, we've been badly failed by the medical system. I'm only 68 and I think they've wrecked me. I've cost the NHS thousands because this wasn't stopped many years ago. Yeah. However, it was only March of last year when I was hospitalized with severe AFib plus new angiosperms that a Polish lady cardiologist came onto the ward and said my calcium was out of range. Had been for some time. She wanted PTH tested. In 5 years, no one else picked it up. Nicole, this is such a common thing that happens. Obviously it happens more in women. This is a disease. All hormonally related diseases happen more often in women. Thyroid hormone abnormalities and thyroid tumors, parathyroid tumors and parathyroid hormone abnormalities, they happen more often in women because your hormonal system is more dynamic and more taxing. Every month when you prepare for your life, when your body prepares for life for decades, your hormonal system has to catch up and go on DEFCON 4 and be ready for the potential of a new life being created, in which case means it's taxed more, it works more. Your bodies are working harder than a man's body. So especially your hormonal system, your endocrine system. So it gets into trouble more so, right? And then you also get dismissed more by, how to not be so insulting, by doctors who are ignorant of this disease and ignorant of women's conditions in general, right? And then we get into this trouble. I mean, that's neither here nor there. But I have to say, men who have this disease are also ignored because the symptoms are not clear. These are not clear symptoms, right? If you go in there with, if you walked in there with all of this many symptoms, let's say you didn't have these last two. You walked in with all of these symptoms here into 100 doctor's offices. I bet you, just by looking at these symptoms, not a single one would say you have hyperparathyroidism. Not one. And you can try all sorts of specialties. That would not be the first thing they would say. It's just not. Okay? And so men get ignored too and go on for years and years until they get into trouble, right? But I think women get boxed into other diagnoses more easily and more readily, and which distracts and deviates, and then they have a harder time coming back to where the problem is until they become their own advocate and say, hey, I noticed my calcium numbers are going up. These are my symptoms. Let's look into it, right? And that's a common thing that happens. All right, moving on. Nicole Michelle, thank you for always sharing your knowledge with the group. My pleasure, Nicole. 1 year post-op, 3 glands removed for hyperplasia. Do you need to take calcium supplements? And depends. It all depends on your diet. I prefer people getting calcium from their food rather than from supplements. So if your diet is high in green leafy vegetables, broccoli, spinach, kale, almonds, right, or dairy, then you don't need to take it. If your calcium numbers in your bloodstream are pretty steady in the normal range and you don't have symptoms of low calcium, and if you've had bone loss on your bone density study, if you had bone loss, terrible bone loss, then I would let the calcium and PTH numbers on your labs guide your supplementation, right? If your calcium is running low and your PTH is running high, yeah, okay, a year post-op, that means you're not getting enough calcium in your system and the remaining parathyroid is working harder, right? And they're not allowing the calcium to get into your bones. So you need to do that. How often should you at least check your calcium, PTH, and vitamin D once a year at a minimum? With hyperplasia patients, it may be a better idea to do it every 6 months because you have a fourth parathyroid gland that's not normal, and that you may want to figure out that it's overworking sooner rather than later. Okay? Is it possible on occasion to have a low calcium and get lip tingling? Yes, it is. It is possible because you have that curve, and sometimes you may be, even if your parathyroid has gone back to normal, right? And this is your curve. Here, let me clear. So this is the curve that you're on, and on occasion you may find yourself here with a really low calcium and you get tingling, right? But your PTH would be very high. So that's possible. If it's brief moments, if it's like, last half an hour, and if you take a little bit of extra calcium, it normalizes, then you're okay if your calcium PTH numbers have been normal in the past year. Magnesium is also important. Vitamin K2 is also important. So if your diet doesn't have a source of magnesium, if K2 comes from pickled vegetables and from fermented cheese. So cheese, if you have a lot of cheese or pickled vegetables, then you may not need the K2, and then magnesium is in all sorts of things, right? So I would make sure you get not only calcium and vitamin D, but also magnesium and vitamin K2. Karen Nelson, can you comment on my treatment plan? I'm 2 years post-op, 2 adenomas removed. PTH didn't drop as low as the surgeon wanted. He located one other parathyroid that was normal and closed after approximately 3 hours. PTH has remained high or upper reference range, while calcium remains steady in the midpoint. Vitamin D, normal with supplements. Taking calcium endos, hoping this would stabilize drop PTH, but it didn't. I mean, if you're 2 years post-op and your PTH numbers are, if your calcium is in the middle of the normal range, right? And your PTH, calcium is in the middle of the normal, let's say the box is the normal range, and your PTH is hovering here, right? That means there's something wrong, okay? Then you now have normal calcemic hyperparathyroidism. That means you probably didn't have 2 adenomas, that you had hyperplasia, right? Now, 3% of people have only 3 parathyroid glands, okay? Let me show you. So 3% of people have 3 parathyroid glands. So it's possible that the gland that your surgeon left behind was appropriately done, or it's possible that you have an ectopic parathyroid elsewhere. So 2 years post-op, if you're still having high PTH numbers, you have persistent hyperparathyroidism, more than likely you have hyperplasia rather than a third adenoma that's in your chest. But what I would do is repeat your ultrasound. If that doesn't show any 2 parathyroids in your neck, then a 4D parathyroid CT scan, and I would do the full set of labs again, calcium, PTH, vitamin D, 125 dihydroxyvitamin D, and a 24-hour urine calcium, just to get a better view to see if you want to proceed with further surgical care. If your scans are negative, right, and you don't see it, and your surgeon is an experienced surgeon and didn't find it, then another parathyroid surgery may be challenging to do, right? If, on the other hand, you speak with your surgeon and your surgeon says, I do parathyroid surgery, but I'm not the most experienced, or I will refer you to someone more experienced, and then you will take that lead and do that, okay? Conversation with your surgeon is key at this point. But it seems to me that you have persistent hyperplasia. If scans are negative and your surgeon doesn't feel like it's appropriate to do surgery for you, or doesn't and thinks he's well suited or she is well suited and doesn't think that a more expert surgeon would be able to do anything else, the other option is to use Sensipar to bring your PTH numbers down. And that's another option, okay? Good luck. All right, Karen Nelson, good luck to you, dear. Ellen Fredrickson. I was diagnosed with hyperpara half a year ago. Almost every day I have symptoms like headache, fatigue, and brain fog. Some days I feel better, almost normal, and other days I crashed and couldn't handle my job or taking care of my kids. But last month I felt much better, almost normal, and I don't know why. I haven't gotten any treatment. Can you explain this? Is this common? It is not common to have that, unless for some reason you're now hovering in a different area on that curve. But I would encourage you to check your labs, right? Because you may have had secondary hyperparathyroidism that have normalized. Check your labs again. Check calcium, PTH, vitamin D. Check magnesium level. Check your kidney function, and see what all those numbers show, right? Because if those numbers have all normalized, right, then you have to figure out if you have secondary hyperparathyroidism and if there was any reason for getting a secondary hyperparathyroidism and address it. But if your numbers are still abnormal, then I would say enjoy the lull in symptoms and have treatment as quickly as possible. Good luck, Ellen. Esther Wallan. Hi, Esther. Nice to hear from you again. I read the following. Boron is a trace mineral that supports parathyroid function by helping regulate calcium and magnesium balance in the body. Deficiency in boron can lead to an overactive parathyroid gland, causing excessive calcium to be released in the bones, which can lead to osteoporosis, arthritis, and soft tissue calcification. Calcium-magnesium balance. Studies in animals indicate that boron, especially in conjunction with estrogen, can positively influence the absorption of magnesium and calcium, which are often dysregulated in hyperparathyroidism. Boron is known to influence the metabolism of steroid hormones like estrogen and 1,25-dihydroxyvitamin, which are critical for bone health. What is your experience with this? I don't have much experience, and thank you for bringing it to my attention. I will look into boron and see if there is a connection there. I mean, I can't see how it could directly control the calcium and magnesium balance in the parathyroid cell directly, but I can see how it can do it indirectly, right? If there is, for example, a calcium channel on the surface of the cells, it may need boron to allow it to function more efficiently or effectively, or to open up, and without boron it wouldn't open up and calcium can't get in, and the parathyroid can't see the true value of calcium, and all sorts of things can be going on, right? Or it may affect, I don't know how it's doing it, but I'll look into it and see if there is a direct connection. But Esther, you've always been a good resource, so I'll definitely check that out and see. Because if it is, then it should be a tool in our armamentarium to see if that can affect people who have, unclear reasons for having parathyroid issues. But having said that, if boron is affecting your calcium, right, and it brings your calcium balance low, then your parathyroid would be reacting and be high. I can't see how boron, if it controls calcium balance, would cause your calcium to be high and your PTH to be high, right? So it may affect the calcium balance, but I can't see how it would affect both calcium to act abnormally and parathyroid to act abnormally, other than calcium low, PTH high, calcium high, PTH low, which is normal. I can't see how boron could cause both of them to be high or both of them to be low, right? Which is why getting all the lab numbers and comparing them is meaningful. But I'll look into it, Esther. Lynn Murray. I'm 58 and live in the UK. I'm awaiting surgery this year for one left inferior adenoma after 2 years of semi-regular observation blood tests and scans. I've had a multitude of symptoms of developed kidney stones since being diagnosed. My numbers have ranged from 2.7, PTH of 14, these are high numbers. Most recent was calcium is now lower at 2.55, upper limit of normal is 2.6, and PTH is even higher at 15. Right. So the set point of the tumor is somewhere between 2.5 and 2.7, right? Or maybe even higher than 2.7. And so when your calcium goes lower, the tumor produces even more hormone. Correct. I'm concerned as my ENT surgeon doesn't perform intraoperative PTH testing, and my endocrinologist doesn't see the need for restarting my calcium supplements post-surgery despite my severe osteoporosis. Status. I'm currently on zoledronate early, which is a osteoporosis medication. Should I question this decision? Yes. Yes, you should. Yes, you should. Now, the UK system is a harder system to fight, but there are studies that show if you've had 2 scans that show the same parathyroid as being enlarged. So let's say you do an ultrasound and a 4D parathyroid CT scan, or the sestamibi and an ultrasound. If both of them show the same lesion as being the same parathyroid as being enlarged, there's a 93% chance that that's the only one that's enlarged, right? So if you have that, you can at least approach it with a little bit more confidence, right? I'm not sure how much how common it is for PTH testing being done in the UK. I remember visiting one of the professors in the UK and going to the operating room with them, and they were telling me that they have decided not to do intraoperative pathology testing, right? And this was a decade ago, so I'm not sure if PTH has gone by the wayside as well. I do PTH testing on every single patient. I may or may not do pathology testing during surgery. I'll do it if I have hyperplasia and I want to confirm that what I remove is parathyroid. In adenoma cases, it's not always necessary, but I do the PTH testing because it helps me figure out problems in about 15 to 20% of people, right? And that's an immense proportion of people that get helped by doing a PTH test. So I do it all the time. So I would encourage you to find a surgeon that does. And then in terms of taking calcium supplements after your surgery, it doesn't matter if your doctor doesn't believe in it. I would say you can either download from my website the supplementation, or I'll put it up for you here so you can look at it. This is it. Unfortunately, this is not in the UK nomenclature of calcium, right? But you can convert these numbers and then take, this is the number of pills the first week, second week, third week. And if you don't have access to calcium citrocalpetites in the UK, you can find something close in terms of how much calcium and vitamin D it has, and follow this regimen. All right, my dear? And Jill Hitchcock responds, bisphosphonates are contraindicated in primary hyperparathyroidism. They're not contraindicated, but they are, I'm not sure if they are helpful. I don't know if the bone that they form isn't well organized in terms of architecture. I just don't know. Okay, and Jill Hitchcock says, I myself got referred to Paul Dent in Croydon. There are a few others in the UK. You can get referred to a surgeon in another trust who does do for gland and PTH testing. All right, Jill says you can do that. All right, go for it. Good luck, Lynn. Hopefully my chart is helpful to you, and hopefully you'll find a surgeon that is going to meet your needs more appropriately. All right. Emmy Guttenstein had parathyroid surgery April 2024. Surgeon could not find parathyroids. He did cut a blood vessel and the PTH dropped. I still have so many symptoms, but my blood tests are normal. Calcium is 10, PTH is 52, just a few months ago. But that's not normal, dear. So your calcium is upper side of normal, right? Calcium, if the box that you see here is the range of normal, your calcium is 10, normal range is 8.8 to 10.2. So you're at 10, and your PTH is 52. Normal range is 15 to 65. Your PTH is also here, right? This is how parathyroids normally function. You're functioning here. Repeat your labs, fasting and at 8 o'clock in the morning, right? 1 week apart. You can do 3 labs, 3 weeks, one at 8 o'clock and fasting in the morning without biotin in your supplements at all. And see, if these numbers stay up here like this and you don't get wide changes in those 3 values, then you still have hyperparathyroidism. You're just in the normal range. You had hyperplasia, and you need to have it addressed. If your surgeon didn't find any parathyroids and cut a blood vessel, you have no idea how many of the parathyroids got affected. So let me show you the anatomy of parathyroids. So This is the thyroid gland, and the 4 parathyroids are usually deep to it. And when you zoom in, you can see this parathyroid gland is getting, and this parathyroid gland, right? So they're both getting their blood vessel from here. It goes up and it comes down. And they both have, and this one has blood flow going out of it here, while this one has blood flow going out of it from another source, right? Generally speaking, they're usually combined, but nonetheless. So if in this person, this blood vessel got clipped, then these 2 parathyroids may not have any blood flow and they both may die. But then that doesn't do anything to the parathyroids on the opposite side. And so if 2 scenarios, if you had 2 adenomas, if you had a normal parathyroid here and an adenoma here, and a normal parathyroid gland here and an adenoma there, then when you cut this blood vessel and kill these 2 parathyroids, you still have another adenoma there functioning, right? If you have hyperplasia, where all 4 of your parathyroids are abnormal, right, and you cut this blood vessel and these 2 die, you still have 2 abnormally functioning parathyroids. And you clearly still have not normally functioning parathyroids. So I think you need to look into this more. So you may have an ectopic. Again, if you had 2 parathyroids, one here and one which was supposed to be in this parathyroid, but if this parathyroid is all the way in your chest, it doesn't, cutting this here and cutting here and killing these 2 obviously won't affect that. So that's a possibility, right? But the true answer is that you still have persistent hyperparathyroidism, cause unknown. Ectopic parathyroid, another parathyroid adenoma, or hyperplasia, unclear based on this. We don't know how many parathyroids are alive or dead. And if your doctor cut the blood vessel here, only this parathyroid died, so maybe you have 3 parathyroids that are still alive. All right, too many unknowns there. I have a large thyroid nodule. Can they hide there? Yes, it can be, the nodule itself could be a parathyroid, or it can be squished right next to it, right? Just had an ultrasound. It was recommended to do another FNA. If you're doing an FNA of that nodule, I would still tell your doctors to send a second sample of that nodule for parathyroid hormone testing, because there should be no parathyroid hormone or exceedingly small amounts in the thyroid nodule if it's not a parathyroid tumor. My thyroid is a mass, just a little healthy tissue. Does one just keep it or remove it? If my thyroid is a mess, just a little healthy tissue, I would have to get more information, Amy, to know. If you're saying your thyroid is a mess because it has a large nodule in it and the remainder of the thyroid is healthy, then yeah, you should try to keep as much of it as possible. On the other hand, if you're saying it's a mess because it has Hashimoto's and you have 20 nodules all over the place and your hormone levels are low, then it's not really servicing you, and that's a different question and a different answer. Good luck, dear. B. Pagnota Caria. I'm 69 years old and have been severely osteoporotic for almost 40 years. I was finally diagnosed with hyperparathyroidism. Hallelujah. And had a parathyroidectomy 6 years ago. I was hoping my osteoporosis would improve, but it has not. Is this normal? No, it's not. I have not seen a person whose osteoporosis hasn't improved unless they had severe female hormone abnormalities that were not addressed at the same time, or had a genetic condition. Was it wrong to expect improvement in my numbers? No, it's not wrong, B. Your numbers should have improved. Usually at 2 years after surgery, the bone density numbers should improve. Could I still have issue related to the disease? Yes. I would check your calcium, PTH, vitamin D numbers now fasting and at 8 o'clock in the morning to see if there is an abnormality there, because if your numbers have not improved, then it's possible that you still have hyperparathyroidism or you have a recurrence of it. By the way, I had a DEXA scan about a year after surgery and my numbers were better, but still in the severe osteoporosis. 1 year is too early. Usually I see changes at about 1.5 to 2 years. So repeat the bone density study now and repeat the last. Oh, so you say 5 years later, the bone density study shows no more improvement. Yeah, again, repeat the labs because you may still have persistent hyperparathyroidism or recurrent. Rebecca Solberg, had my surgery 10 years ago. Best thing I've done, got my life back after surgery. Thank you for sharing, Rebecca. I mean, this hyperparathyroidism can have massive impacts, and there's certain people who come and see me and have absolutely no symptoms. But when we do surgery, even for those who have no symptoms, their bone density improves, which is why your lack of improvement is alarming, right? And oftentimes, obviously, we find patients like Rebecca who it's life-changing, okay? Jackie Wild Ferguson, how can a missing parathyroid gland be found once all other scans, nuclear CT, etc., have come back with nothing? I've had surgery February last year. Two removed, one okay, one missing. I'm not having magnesium issues, low calcium, but high PTH, and I feel I can never. Well, listen, if you had surgery and you had 2 parathyroids removed and your calcium and PTH numbers, if you had PTH testing during surgery and the PTH numbers came down, that's great. If you haven't had PTH testing, but your labs are now show a low calcium and a low magnesium and your PTH is high, well, both of those normally cause high PTHs, right? So let me show you a different graph so it's not confusing. Secondary causes of PTH being high, right? So low calcium intake, malabsorption, so low calcium absorption or low calcium intake, and low magnesium will cause your PTH to be high. So if you have low calcium and low magnesium and your PTH is high, you have secondary hyperparathyroidism, not primary, and that is solvable, Jackie. You just need a good doctor to help you through it, right? So I would take a picture of this slide and have your doctor explore. If you're taking any of these medications, that could cause PTH elevation too. Do a 24-hour urine calcium, right? To see what's going on there, all right? But it doesn't look like you have primary hyperparathyroidism, it looks like you have secondary. Be crystal clear on Instagram. Hands down, best ENT in Los Angeles, full stop. Thanks. Thanks, crystal clear. Golden Tara, I had a subtotal parathyroidectomy on December 10th, 2025. Since then, I've struggled with hypocalcemia and feeling unstable and unwell because of it. I'm sorry, Tara. I have osteopenia and low vitamin D. My endo put me on calcitriol 0.25 milligram couple weeks ago, and it seemed to double my need for calcium, which was already high. It also seemed to lower PTH and magnesium. Well, it should lower the PTH for sure. That's a good thing. All calcitriol does is calcitriol is the active form of vitamin D, right? So if you have no parathyroid function, right, and you're not making any PTH, well, you are making PTH, so you must have some parathyroid function, right? So they did a subtotal, which means they remove 3 of them, and a portion of the 4th one, So you have some parathyroid here, all right? And you're producing some PTH, all right? Recalcitrol or calcitriol is this. And calcitriol is the active form of vitamin D, and that's what goes to the kidneys and to the intestines and increases the absorption of calcium from 28% to 80%. Right? Without this, you are not really absorbing calcium. Okay? So by taking this, you're increasing your calcium absorption, right? Which would bring your PTH down. All right? Now you said it increased your need for calcium. You'll have to show me numbers, Tara, for me to understand what you mean better. Okay? Does that mean that by taking the recalcitrol you were getting tingling more, so you took more calcium? Or what does that mean? Right? I would love to hear from you so I would understand, okay? I'm assuming bone remineralization is going on for sure. How long does that typically take? That typically takes, it all depends on the degree of bone loss, right? If you have osteopenia, it should be done within a year. If you have osteoporosis, year and a half. If you have severe osteoporosis, probably 2 years, okay? Listen, having low calcium is going to make you feel unwell. Having high PTH makes you feel unwell. So if that's the combination that you've been living with for a while, the calcitriol can potentially normalize all of that. So calcitriol is what I would have suggested to you, but I would also suggest taking magnesium supplements as well and vitamin K2. All right, my dear, good luck. Ulysses the Great. I have stage 3 kidney failure that I found out only last year, together with my primary hyperparathyroidism. Doctors don't know what appeared first, but the kidneys to be the size they are now. They shrunk significantly. I must have had this condition for several years, although testing always came normal. As for the hyperparathyroidism, it was found due to further testing on my kidneys. Calcium was high, somewhere between 10.6 and 11.6, so really high numbers. As well as PTH also has been ranging from 211 to 420, and now back to 240. I have now all the symptoms associated some amount to 2021 with high blood pressure and low vitamin D, even taking supplements. 2025 were the worst years with bone issues all over the bone, pain, stiffness, osteopenia, chest pain, palpitation, poor eyesight, gastritis, hiccups, fluid retention, fatigue, memory loss, mood swings, the package. My question has to do with the impact of my surgery on my kidneys. What am I expected to expect on that level? Well, if your calcium is so high, your kidney is doing extra work to do the filtration. So less duress on your kidneys directly, but also high calcium produce kidney stones, and so it would remove the possibility of microscopic kidney stones affecting kidney function, right? So it's a good idea to take care of the parathyroid, especially if you've done a scan and you see one parathyroid adenoma, one enlarged gland as primary, then that's an easy surgery without a lot of undue stress on your kidney. And then you're asking if you should take vitamin D. You should check your regular vitamin D, which is the regular blood test, and 125. If your 125 vitamin D is very, very low, then taking this won't help, because your kidney is not there to produce that, and you will have to take recalcitrol. Okay. The effects of surgery. Ulysses is asking, statistically, are the effects of surgery more positive than negative? Absolutely. Absolutely they are. And in your scenario, I think very necessary. I've read a lot of comments from patients who felt worse and kept getting going for a second and third surgery because of the abnormal glands had grown. Well, I mean, if they didn't have the appropriate surgery, if they had, if they didn't have the appropriate technology available for the surgery, or the surgeon wasn't experienced enough and so on, you can have other surgeries. So I urge you to find an expert surgeon to do your surgery. But once you have surgery and hyperparathyroidism is cured, you may not feel better immediately, but based on the quality of life service that I do with my parathyroid patients, almost everybody feels better. Sometimes it takes 2 years to feel better, but almost everybody feels better after some time. Some will feel better in the recovery room, and some will take months, some will take years. But in your scenario, with the kidney function as it is, you should definitely have treatment. Finally, since I have kidney disease, does that not mean that I will inevitably have recurrent high PTH? Well, it depends on the severity of your kidney disease. If you still are making urine, and if you're still making normal levels of calcitriol, that means you have adequate functioning of your kidney, in which case your PTH shouldn't be high. All right? But on the other hand, if you're not making urine, or your 125 is close to zero, which means your kidney is not functioning enough and this enzyme is not available for this transformation, then you will continue to have problems, and you need to address it appropriately. Or it may be that you have hyperplasia and that you need a subtotal parathyroidectomy. And I'm in Portugal, and I'm wondering what questions I should ask. So, Ulysses, how many surgeries they do? Do they do PTH testing? Are they concerned that in your scenario that you may also have parathyroid hyperplasia despite a scan showing maybe one gland being abnormal, right? What kind of scans are going to be done? Is it just ultrasound, or are they going to do a sestamibi scan or a 4D CT scan, which may not be appropriate because of a kidney malfunction, right? Good luck. Just make sure your parathyroid surgeon does more than 50 parathyroid surgeries a year. That's the key. Faith, I had a parathyroid gland removed in 2022. Afterwards, I was experiencing a lot of tingling, and the doctor told me to take Tums. It has been years, and I'm still experiencing facial tingling, sometimes so bad that it affects my vision. Everything falls asleep fast on me also. Also, I have to do is lift my arms or sit crisscross, and they fall asleep within 5 seconds. I'm always tired, also my leg. Any suggestions? Well, Faith, you have to look at your calcium, PTH, vitamin D numbers to see if you still have persistent hyperparathyroidism or hypoparathyroidism. Because if you had parathyroid surgery, right? So let me show you. When you have hyperparathyroidism because of a single gland, an adenoma developing in a single gland, which means you had a tumor from one cell growing and growing until it became a tumor, right? And as it's growing and producing more and more PTH, the normal glands shrink and get smaller, right? So if you had a parathyroid surgery where you had a 4-gland exploration, and then they removed one, right? So they removed this one, but they looked at the other 4, and in the process of looking at the other 4, or the other 3, I'm sorry, they damaged the blood vessel going in and coming out. If either one of these gets damaged, that parathyroid dies. So I encourage you to look at your calcium, PTH, and vitamin D now to see if you have adequate parathyroid function. If you don't, then you need to treat that. And if you don't treat it, you're going to continuously have symptoms and feel awful. And you deserve better. But look into it, dear. Please, please, please. I don't have enough information to be able to give you a good answer. Hopefully this at least starts you on the right path. All right. So that's for the questions that came in. Let me look at the questions that have come during our conversation here. Okay. Nancy Lindsay, Dr. Larian, I'm so sorry for you and your home country losses and pain. Thank you very much, Nancy. It is heartbreaking. It's beyond words. Thank you for saying that. Ijabu Hussein, I've hyperthyroidism, but my doctor says drink milk. It's related to your lack of dairy intake. But I have my doubts because I have drinking milk for 2 months and I don't feel any different. I mean, if you're saying you have hyperparathyroidism, meaning your PTH number is high, if your calcium is low, then your doctor is correct. But it could be that you have malabsorption or dairy intolerance and you're not absorbing the calcium, and that's why it continues. So I would have to look at your number, Job, to see. Oh, crush. Dr. Larian, first and foremost, I'm sorry for what you're feeling and what has been happening in Iran. My prayers are with you and those in Iran that are suffering and have lost loved ones. Thank you. Thank you very much. I appreciate that, really. Sweet taters. Just joining, can celiac disease make it hard to get vitamin D up even with very high doses? Yes, but fortunately, if you have vitamin D sublingual drops, they don't use your intestines and celiac disease won't be an impact. So, and I really encourage sublingual vitamin D. It's be easier, more reliable. Okay. Kathy Nimani. Let's see. Okay, Kathy Nimani says it wasn't 30,000 units of injection, it was 300,000. I've never heard anybody getting vitamin D at that level of injection. Nancy Lindsay, endocrinologists need to come up to speed on parathyroid issues. Yes, they do. Whew, yeah. At the Lake 510, I'm working to get my vitamin D up. It is 19, taking 5K daily. Last calcium was 10.3, PTH was 33. Doctor wants me to take a bit more D. Is 5K enough? I have one gland left. Oh, so you have parathyroid hyperplasia. So you have one gland left, your calcium is high at 10.3, and your PTH is on the lower side. So no, I don't think vitamin D is going to solve your problem. Your calcium is too high. If your calcium was low and your vitamin D was low and your PTH was higher, taking more vitamin D would solve the problem. But if your calcium is high, upper limit of normal is 10.2, you're at 10.3, and your PTH is in the normal range but not suppressed below the normal range, then you have persistent hyperparathyroidism. And I don't think taking vitamin D is going to solve that. I would check your 125 dihydroxyvitamin D and 25 urine calcium, and based on that decide if you need maybe support with recalcitrol, because as we get older, our intestines don't absorb as much calcium, but even in that scenario, your calcium would be low. I just think you have persistent hyperparathyroidism, and you may need to either consider Sensipar or revision surgery. I would revisit this with my surgeon at the lake. Okay, what is the medicine doing to change the doctor's views and knowledge about it? Absolutely nothing. The healthcare system is not doing anything to change the doctor's view and knowledge about hyperparathyroidism. I had a half an hour lecture in all 4 years of medical school on hyperparathyroidism, and I saw maybe 2 patients during medical school that had hyperparathyroidism, one of them who happened to be my dean's wife, and ironically, it was during the second year of medical school, and during the second year of medical school, they would have us take history of patients, and my patient didn't show up, my actor patient didn't show up, so the dean's wife was kind enough to come and share with me her history and so on. And so that I didn't even see her clinically. She just mentioned it to me, right? And that was one, and then the other patient had kidney failure and was on dialysis. So and there's just the experience is lacking in this. And there's not a lot of money being put into research for hyperparathyroidism, and I really need an advocate, someone who's willing to stand up, someone famous who's I need Oprah. Oprah can change this, right? Oprah can change this. Michelle Obama can change this. Angelina Jolie can change this. Someone who fights for people, right? Who's willing to step up. They can change this. But at this point in time, it's not sexy enough, and someone famous is not advocating for it, and you guys certainly could use the help, and I certainly could use the help to pass on the message. Okay. Linda Lewis 1. Hi, Dr. Larian. I'm sorry that I'm tuning in late, but as usual, I was asleep. On your last live, you kindly listed my plethora of issues. Things have changed for me even this short time. Good. So you had mentioned that you'd be happy to look at my information even though I'm on the East Coast. How do I contact you, doctor? Is there any way I can call your office? You can do it either way. You can call my office. You can just Google me and tell my staff you want to arrange for a Zoom consult, a video consult, and I'm happy to help. They'll let you know what labs, what scans, or whatever you have, how you can pass it on to me, and I can set up a video call and go through it and try to help as much as I can. All right, my dear? I'm very happy to help. Oinestep. I just got my surgery on Friday. Hopefully recovery will be quick. I already feel improvement in bone pain. Just like I've always been saying, bone pain is the first thing that gets better. Even in the recovery room, people will have an improvement in bone pain. So, case in point. Thank you. Good luck. Oinestep. Be active. Don't be bedbound. The more active you are, the more you force calcium rebalancing. Make sure you have a lot of calcium in your diet. Make sure you have a lot of vitamin D in your diet. Magnesium, vitamin K2. Not only do physical activity, do memory games, crossword puzzles, Sudoku, all sorts of memory games. They will help you, all right? They will help your recovery. Okay. Aesthetic CS Pro? Isn't there a subclinical HPS not seen in labs? I don't understand what you're asking. Sorry. Linda Lewis. Dr. Larian, I'm just looking at other comments here. I'm so sorry for what's happening in your country. When I was a teenager in the 1970s, babysat for a family whose dad was from Iran. Ah, thank you, love. I appreciate that. One world, guys. One world. We're all in this thing together. But it hurts when you have family members who are just living a nightmare. It really does. It's hard. Anyways, moving on. Sweet taters. I'm not diagnosed yet, but if it looks like I do have celiac, the 2 weeks of gluten challenge was horrible. I will get the vitamin D you mentioned. Great. Good. Linda Lewis, they became dear friends of mine. I will keep you, my old friends, and of course the people of Iran in my prayers. Thank you very much. Get choked up so easily nowadays. Anyways, Kathy Pimani, yes, that's right. 300,000 units took two years to bring up vitamin D from 21 to 65, and all it did was raise my PTH. Yeah, I don't think that was the source of your problem, Kathy. Freddie Elliott, 19. Also, my PTH dropped intraoperatively from 111 to 18. I think those are the US measurements. Yes, that's incredible. I mean, that's what you're hoping for, but I would track your numbers now and see how everything is doing, okay? Jason Bruno, I have calcium at 10.3, PTH at 55 with kidney stones, brain fog, insomnia, fatigue, high calcium in the urine. My scans are normal. Can I have hyperparathyroidism? You do have hyperparathyroidism. You have normal hormonal hyperparathyroidism. Your calcium, again, your calcium is above the range of normal. Let's see, above the range of normal, and your PTH, instead of being low, which is normally how in a normal parathyroid environment they function, your PTH is right up here. So that is abnormal. You have hyperparathyroidism. If your scans are negative, right, and you've done all of it, ultrasound, 4D parathyroid CT scan, system UV scan, they're all negative, then you may have parathyroid hyperplasia. Find an expert surgeon. All right, I'm not going, but Freddie Elliott, 19. If you ask the question, it has, let me see, let me go, let me see if I can find you. Freddie Elliott, your question hasn't come through, my friend. Go ahead and ask it here. Aesthetic S Pro. I mean, 3 glands removed in October 2025, 10 years of high calcium osteopenia, passed some kidney stones, so low oxalate diet post-op, normal labs, but had muscle pain. Taking calcium supplement, 1,500 milligrams, justified. Yes. Yes, absolutely. Especially if you don't have aesthetic S Pro. If you don't have a lot of calcium in your diet, definitely take calcium citrate, for sure. But you have to take vitamin D, you have to take magnesium as well, and I would take vitamin K2 as well. So Jason Bruno, Mount Sinai endocrinologist in New York, are telling me it's unlikely I'm going to arrange a consult with your office today. Okay, I'll be happy to help. Freddie Elliott, it's on the Instagram live stream reminder post. I'm sorry, Freddie, it hasn't come through. Can you just type it in here, and I'll wait for you, and I'm happy to answer it. Right. Mandy Franklin. Let me see, Mandy. Let me look at see if you gave me other numbers. Let me find you. Hold on one second, Mandy. Oh, all right. Okay, I had 3 parathyroid glands removed in 2019. I had a CT scan last year and a recent ultrasound. Both scans suggest I have a parathyroid that is enlarged or a lymph node. My parathyroid and calcium are both normal still. Mandy, if you're feeling well and your calcium and PTH and vitamin D's are all normal, right, then this is quite possibly either your 4th parathyroid that is slowly getting larger and you just need to look at the numbers, or a lymph node, right? And I would, if you can see this on ultrasound well, then I would repeat the ultrasound in 3 months, 4 months, and see if the mass is growing. If it's growing quickly, then I would do a biopsy of it, okay? Hopefully that's helpful, Wendy. All right, Amanda Grace Lyon. I'm having my 2nd parathyroidectomy, and I am wondering how risky the 2nd procedure is and how likely is it that this would come back a 3rd time. Well, the risk has to do with your 1st procedure. If during your 1st procedure, they went in and they removed only this parathyroid, they found the nerve to your voice box right here, right, on this right side, let's say. This is the left side, and they found the nerve, they tracked it from here to here. Then they removed the parathyroid that's sitting right over it. They did not go up there or on the opposite side and create scarring. Then your 2nd surgery is significantly less risky, right? Because there's not a lot of scar tissue. On the other hand, if they did a 4-gland exploration where they looked everywhere and they dissected the nerve out on both sides, then the 2nd surgery carries a lot more risk because you have scarring, okay? How likely it is for you to need a 3rd surgery? I would need a lot more information to know that. I would need to look at your pathology report and surgery report from your 1st surgery, and then based on that, let you know if I think you have hyperplasia, and look at your labs and current scans, and let you know if you have hyperplasia or not. And I would need to know when you did the last surgery. If your last surgery was 2 years ago and now you have it, then you have pretty much persistent hyperparathyroidism. If that one was 10 years ago and your numbers were good for 10 years and now they started coming up, then you have a reoccurrence. And a reoccurrence is more indicative of a 2nd adenoma rather than hyperplasia. So all of that information is helpful, Amanda, right? You just need to make sure your current surgeon is looking at all this and has a lot of expertise, that they use a breathing tube that monitors your vocal cord nerves, and they do PTH testing during surgery. Freddie Elliott, I'm looking to see if I can find your message. I'm not on Instagram right now. I'm on Facebook and YouTube right now. So if it comes through to YouTube or Facebook from Instagram, then I'll see it. Otherwise, you may have to type it in, my friend. And right now, I can't go opening up other apps. I have a lot going on here. Anyway, Laura Given von Schritz, thank you for having these lives. They are extremely informative. By chance, do you know if primary aldosteronism and primary hyperparathyroidism are connected? Well, in ME, in some of the MEN syndromes, well, not primary aldosteronism, right? That's not part of MEN. But I have to say, I have seen a number of my patients who've had hyperparathyroidism have aldosteronism as well. And the other thing is that there are parathyroid receptors in the adrenal glands me see. So there are parathyroid receptors in the adrenal gland that may cause the adrenal system to malfunction. So it's possible that it may be playing into that. Okay, good question. Had surgery August of 2025 and had 2 additional adenomas removed. Had 1 removed prior, so only 1 left. Since October, I've been having muscle twitches. Daily. I've gone up and down on the calcium, currently taking 500 of calcium carbonate, 100 of losartan, and 25 of spironolactone. My blood work looks great. Calcium 9.5, vitamin D 60, PTH 23. My electrolytes are normal, so no one can tell me why I have these twitches. Concerned as something isn't right. I'm wondering if taking calcium is messing with losartan or spironolactone. I don't think you need to take calcium. Switch to having, excuse me, pardon me. Switch to having calcium through your diet, right? Green leafy vegetables and almonds, and see if that makes a difference. But the other thing you can do is check your 24-hour urine calcium as well, to see where that is, and see if spironolactone is somehow having an impact on your kidney that's affecting it. Jilishkai, I can't sleep. I can't see palpitation if on your chart. They are, yes, because that chart doesn't show all the symptoms. It shows the most common symptoms, and palpitations and AFib are not the most common symptoms. All right. Emily Beasley, how do surgeons know if they have if they're successful during surgery? If patients has normal hormonal hyperparathyroidism, having surgery, it's good, very good question. So the range of normal hormone is 15 to 65, right? People who have normal hormonal hyperparathyroidism are more sensitive to parathyroid hormone, right? So their range of normal, instead of being 15 to 65, may be 5 to 20, right? So we're not looking at the value of your PTH going into a normal range because you're already normal. We're looking for a more than 50% reduction in your PTH. So if your PTH is 50, we want it to come down to be less than 25, preferably around 15-ish, right? So it's the drop that's meaningful. So having surgery soon, because I'm concerned, because my PTH is always normal, but I do have at least 1 adenoma, and I've had hypercalcemia, multiple kidney stones, bone and joint pain, and brain fog since 2023. PTH always in the 40s and calcium between 10.6. Yeah, no problem. The surgery doesn't change, and the PTH testing during surgery will be very helpful. Maria Owens. Oh, you're showing me Mandy Franklin's note. Thank you. I've had 3 removed different years, and now my last one has become enlarged, but mine are showing abnormal. Plus, I'm now having trouble with my kidney again, possible kidney stones, waiting on scans. I see. Okay. Let me see if I can find it. Okay, got it. Mandy Franklin and Maria Owens, thank you for sending that. I think I answered Mandy Franklin already. Okay, Sue Merzanis. I had 2 parathyroid removals in 2017. Today, I have secondary hyperparathyroidism. I'm taking 5,000 units of vitamin D. Do I need to take it for life at this high rate? Sue, it's hard to answer you without looking at your numbers, right? Let me just say, if the 2 remaining parathyroids are not working enough, then you may need to. If you have malabsorption issues in your intestines and you're not absorbing the calcium or vitamin D or both, then you may have to take it for a lifetime. You just have to, if the secondary is purely due to vitamin D deficiency, not to magnesium deficiency, here, let me show you all the things that cause secondary elevation in PTH, right? Vitamin D deficiency, low calcium intake, which 24-hour urine calcium will show, magnesium, which you can do serum magnesium, or you can do red blood cell magnesium to find out, malabsorption, which you can do blood testing, or these medications. Any of these can cause it. If none of these other things exist and the only thing you have is vitamin D deficiency, then you have to supplement that. Maybe go out in the sun. You know, this famous soccer player Ronaldo, he spends $1.5 million a year on trainers, and the one thing he does every day is he takes off his shirt and sits in the sun for half an hour every day to get vitamin D. So it's important. It's very important, right? And you may find other ways of doing it besides taking supplements. I'm not saying you should take off your shirt and sit in the sun. I'm just saying there's other ways too that you can supplement it. Lucy Ariola Tarayo, thank you for sharing information. Calcium supplements can cause kidney stones. Most surgeons recommend high-dose calcium supplements. I have MTH ovarian and malabsorption issues, so supplements would not help. Would food sources be enough? It could be. I mean, almonds have an immense amount of calcium in them, right? And so you can do almond. Take almonds and green leafy vegetables. Yes, they can. Sumer's is calcium is 2.36, PTH is 79, vitamin D is 89. Let me go back to you, Sue, and look at your original message. I had 2 parathyroid removals in 2017. Today I have a secondary hyperparathyroidism, taking 5,000 units. And then my calcium is 2.36. Normal. PTH is 79, which is high. Vitamin D is 89. So you have normal calcemic hyperparathyroidism right now, right? Or secondary hyperparathyroidism, right? But your vitamin D is 89, so it's not because of vitamin D deficiency. So Sue, vitamin D is not gonna fix your problem, or it hasn't. So if you've taken the vitamin D and your vitamin D has come up to 89 and your PTH is still high at 79, then you don't have secondary hyperparathyroidism due to vitamin D deficiency. It could be something else. So look at all the other causes, kidney function issues, magnesium malabsorption, medications, and look at your kidney formation. Do a 24-hour urine calcium as well and see what that is, okay? Still getting kidney stones. Well, your PTH is high, so you are. How do surgeons know, Emily Beasley, how do surgeons know if they're successful during surgery of patients? Oh, we answered that. Esther Wallans, thank you for checking boron influence. I am testing the boron theory by eating plums, and I will see how it will affect my numbers. Please share. I will do my best to look, but please share, Esther. Thank you so much. This is so good, guys. I mean, obviously it's good because it makes me feel good that I can help so many people, at least nudge them in the right direction and empower them. But it's also good because you guys challenge me with questions that I haven't thought about and will look into, and you're making me better, so thank you. Laura Given Valls, yes, Oprah. any of you knows Oprah, please mention hyperparathyroidism, how it affects women disproportionately, and I need a woman to champion this fight. This is, I mean, I'm trying to fight, but I'm not well known enough or have enough clout to get anywhere. All right, but with Oprah, I can do something. Ben Carlson, hi Ben. Do you know any good parathyroid surgeons in Europe, in Germany or other countries? Yes, I know Dr. Khan, Khan at Oxford, and let's see. Hold on, let me find. Shad Khan, Shad, last name Khan, and then also there is the other well-known parathyroid surgeon. His name escapes me. Italian name, who's also in London. Palazzo, Dr. Palazzo in London. Those are the two that I know, right? Palazzo I've seen in the operating room, and Shad Khan I've spoken to. It's very bright, very intelligent, and the patients that I have seen that you've had in common, he's done an amazing job helping them. So those are the two, banked. Try them. All right, my friend. I know you have that parathyroid that's next to that vessel in your upper chest, and I know you've had previous surgery. Try them. John Feeney just stopped to say hi, Dr. L. Still doing great over here. Surgery 5 years ago. John, thank you so much for sharing. My staff showed me a post that you put up a day ago, or they found it a day ago, on I think it was somewhere on Facebook, and I can't thank you enough for being so complimentary. I really appreciate it. It does feel good to know that I've been able to help. Mandy Franklin, yes, thank you. Amanda Grace Ion, they did an exploration because I was pregnant. The first time I could not get proper scan. My last surgery was April 2021. The first surgery was successful. All right, so Amanda, you're gonna have another surgery, and yes, if I'm correct, I'm trying to go back to your message. Let's see. Well, listen, Amanda, you've had 2 previous surgeries, you've had exploration, so the surgeries, you had an exploration the first time around, so your surgery is definitely more risky because of scarring. I would say that you should seriously discuss with your surgeon that this is more than likely hyperplasia, and your surgeon needs to look at the op and path report from your first surgery, the second surgery, so that they know where to go, and then do all the scans in the universe to find out whatever remaining parathyroid you have, so you can have a more directed surgery. Good luck, my dear. Your surgeon should be an expert and should do more than 50 surgeries a year. Freddie Elliott. All right, I found you. Freddie Elliott, let me see. Okay. Hi, Dr. Larian. It's Freddie. I hope you're doing well, and happy Christmas and a happy New Year. Thank you. Thanks for doing this. I just had a quick couple of questions. I had a right superior parathyroid adenoma removed on January 15th of this year. So I'm about 2.5 weeks post-op now. My blood at 2 weeks post-op all showed good signs of successful procedure. Calcium 9.3, PTH 45, vitamin D 21. Okay, no problem. The numbers are good. The adenoma was 15 millimeters, and my surgeon estimated it had been there roughly 5 years. My question: What is the average time post-op when the majority of your patients feel a significant improvement in their symptoms given the estimated? First, there is no way to estimate when you had hyperparathyroidism based on the size of the tumor. You can only do it based on you're looking at your calcium labs. If your calcium labs were hovering, let's say 9.2, 9.4, 9.3, 9.2, and then 5 years ago they went from 9.2, 9.3s to 9.8, 9.9, then 10, 9.8, 10.2, 9.9, 10.3, 10.4, 10.2. That's when you know when the parathyroid adenoma started 5 years ago. Otherwise, you really don't know. Okay? So, on average, when did they feel better? If they had it for 5 years, I don't know if I can answer that like that. I would say the longer you've been in it, the longer it's going to take. 5 years is not a long time, so if it's truly 5 years, based on your calcium numbers, I would say within 6 months you should feel better. Oh, so Elliot writes that the amount of years you've had disease correlates to the amount of months post-op before you fully recover. Don't know. This is not true because it has to do with the amount of time in it and the degree of difference between your calcium and the hypercalcemic state you've been. So the larger the difference and the longer you've been in it, the harder the recovery. How long should you be having blood for the post-op to ensure no persistence? I check blood at 1 month, 6 months, 1 year, and then yearly thereafter. Freddie, my PTH also dropped from 111 to 18, which is really encouraging that you just had disease that was appropriately addressed. Good. Very happy for you, Elliot. Okay. Nicole Lepage. 6 years after hemithyroidectomy, I saw an endocrinologist straight away. He said low calcium, vitamin D. He said my parathyroid glands may have been damaged during surgery, and even if they are there, still they don't work. But I mean, if you've had a hemithyroidectomy and the other side was untouched, that should never be the case. I'm now on calcium, vitamin D, and calcidiol. Okay, my regular endocrinologist oversees my care in the UK. They don't have any knowledge of parathyroid. Don't even explain they could be damaged during surgery. Would you recommend any advice? Appreciate it. I'm due to have my blood work. Please check your calcium, PTH, and vitamin D. Nicole, fasting and at 8 o'clock in the morning, and then share it with us. I'll give you my advice on it next month when I'm on this, right? I can then, I mean, you'll have to write the whole story again, but with your labs, and I can tell you if your numbers are low, if there's anything wrong, because someone who's had a hemithyroidectomy should never, ever have hypoparathyroidism, because so this is your thyroid gland. So this is the thyroid gland. And you have 4 parathyroids. 1, 2, 3, 4. You need only 1 parathyroid to function normally. So if they removed half of your thyroid, let's say they removed all of this and took with them the 2 parathyroids on that side, you should still be able to function normally because of the other one. So what the story doesn't make sense unless there's more to the story, and which I'm sure there is, and then when you share with the labs, then I can help figure this out for you. All right? Very good. That looks like it's the end of the questions. Oh no, there's a few more. All right, hold on. All right. Aesthetic C Pro, thank you, Dr. L. Taking D3K2 and magnesium glycinate. Also, you are the best. Thank you. I've come to see you. I would have come to see you if I could have. I've mentioned you on Facebook, Hyperparathyroid page. I hope that is okay. Thank you. Of course, it's okay. I appreciate it. There's no information out there for so many of us who have no leadership from doctors. Is there a place for us to your patient? Is there a place for us to see your patient surveys again so we can see symptoms improvement? Let me see if I have the surveys here. I think I do. Let me see. Okay. This is sorry. All right. There we go. So this is the survey. Let me magnify it so you can see it. There you go. This is the survey that I do before surgery, immediately after surgery, 6 weeks after, 6 months, 1 year, 2 years, and 6 years. And it's interesting because 0 means always and 4 means never, so it's a little bit counterintuitive. Okay? Anyways, there's the surveys. Linda, Versal, still can't talk after weeks. Blood work is good. Doctor saying my surgery was the most difficult one he had ever did. See an ear, nose, and throat doctor in Linda, so them to look at your vocal cord, see how it's working. A lot of times the vocal cord nerve gets bruised and swollen, and then it comes back, and an ENT can guide you on that. Linda Lewis, I'm going to contact Dr. Oz to see if we can raise awareness of this dreaded disease. It can't hurt, and he knows Oprah very well. He has even larger platform now. Someone needs to help. Yes, do it. Do it. Raven, Dr. L, I have familial hyperparathyroidism. I was diagnosed with type 2 diabetes. During this time, is there a connection between the two, and will my blood sugar improve after surgery? Good question. Sorry. The adrenal glands hold the islet cells that produce insulin, and there's PTH receptors in the adrenal glands, and there's some thought that relationship there is causing some sugar metabolism issues, and so because of that, let me see if I can find. Because of that, there can be sugar imbalances. I've seen patients who it's not a common thing, but I have seen patients who've had better controlled environments after surgery, and I don't know if it's because their body works more efficiently or if it has to do with the sugar balance that's being affected. Again, I'm trying to find the parathyroid hormone receptor. Yeah, again, parathyroid hormone receptor in the adrenal glands, and I'm sorry, in the islet cells, not the adrenal glands. I misspoke. In the pancreatic islet cells, which is where insulin is made. So, yes, there could be a commonality there, a relation. Okay. Habitus Ventures. Hi, I'm from the UK. In 2023, was diagnosed with lingual thyroid that was midline jaw, and then half sitting in the middle of my base of tongue. I had both surgery and then radioactive iodine. Huh, okay. I now have salivary gland issues. Could my parathyroid also be damaged due to radioactive iodine? Yes. So that's why you check your calcium, PTH, and vitamin D to see if you're producing enough PTH, or vice versa, if you're caused hyperparathyroidism when you have an excessive amount of PTH. That can happen with radioactive iodine too. Good luck, dear. Candy 7780, what about high lipase levels with high calcium, high PTH, and low vitamin D? High calcium levels can cause pancreatitis, which can cause high lipase levels. So this is very concerning. Please see your doctor so they can check your pancreas and make sure it's working okay, because if it's not and you have surgery, you can get into trouble easily. Abu Hussein, I had surgery 4 years ago and they removed 2 glands, but nothing changed in my symptoms, but they say I have secondary, told me to take dairy products. My PTH is still high. If your PTH is still high, I mean, you may have secondary, but you may still have persistent hyperparathyroidism. I would have to look at a lot more numbers to see what's going on, my friend. Linda Versal, parathyroid was huge and wrapped around the vocal cord, which caused the vocal cord nerve damage. That does happen, but the nerve can recuperate despite being damaged. Okay, it can be, and it is hopefully short term. T. Cancella 7286. My lab's upper limits of normal is 88. My PTH was 80. Calcium 9.4. Normal vitamin D. I'm 52 and have wrist fractures leading to DEXA showing osteopenia. Because my PTH is normal, my internist says fine. It's not fine. Your calcium is in the mid-range of normal. Your PTH is on the upper side of normal. You need to repeat this lab fasting and at 8 o'clock in the morning 2 more times. It can be 1 week apart. And look at the pattern. If the pattern shows that your calcium is always mid-range of normal or higher and your PTH is always high, that's not normal. I have fatigue, muscle weakness, high blood pressure, and would like to repeat PTH. I'm a pediatrician myself, so don't know what to do. So don't want to be that difficult. No, but you're a physician. And if you're a physician, you can talk to your physician in medical language and say to him or him, if my calcium is in the mid-range, why is my PTH high or high normal? Why don't I have variability? And that's something that happens. In a normal parathyroid environment, you naturally follow this curve, right? And so if your calcium, let's say, if your calcium is set to be 9.5, right? Your PTH should be 50% of your highest level, right? So your PTH should be in the 40s, right? If your graph is different, maybe you have this graph, right? And so your set point is 9.2. At 9.4, your PTH should be low. And at 8.5, it should be high. Maybe your graph follows here, right? And at 9.4, your PTH is high, right? If that's the case, that means your calcium is too low. And if you supplement with calcium and vitamin D, you can go and come here. And if you get to a calcium of, let's say, 9.9, and your PTH is now lower in the 40s, then all you needed was more calcium. Do a 24-hour urine calcium and see what that shows. All of those numbers will help you, okay? But there's clearly something going on. All right, scorpions, angels, always somewhere. PTH is high and my calcium and low vitamin D. I have an isthmus nodule, 2 centimeter. My left lymph nodes get painful and swollen. I can possibly have cancer in that nodule of my isthmus. Possible, but lymph nodes wouldn't be painful with the cancer. They would be painless and enlarged and firm. And if your nodule is firm and at the isthmus, it's very easy to biopsy, you can get an answer very quickly. So please do that. But if your PTH is high, along with your calcium, you may also have hyperparathyroidism. So have them look into that. T. cancella, I will advocate for two repeats of labs at 8 a.m. Also take low-dose lithium. Low-dose lithium can cause parathyroid hyperplasia. So also discuss that with your doctor. All right. I think we are done, my friends. Have a wonderful day. Thank you for your wonderful questions. Thank you for your touching and caring comments. I really do appreciate it. I hope something meaningful happens to Iran and I get to go back someday and visit. And I wish you guys all well. I wish for peace and love and unity everywhere. Hopefully we can get there. All right, be well. See you guys next month.